Next, we'll hear the AANS presidential address delivered by President Shelly Timmons, introduced by Dr. Rick Boop.
Well, thank you. It's a tremendous honor for me to introduce to you your 86th president. Shelly Diane Timmons was born on August 30th, 1965 to Galen and Diana Timmons in West Central Illinois. She and her brother David spent their early years growing up on a farm near London Mills. In childhood, Shelly set her sights on becoming a physician, having been captivated by the family's medical encyclopedia. After reading about an article about brain surgery at the age of 16, she was certain that neurosurgery was her calling. Shelly attended Spoon River Valley High School, where she excelled academically, graduating as valedictorian, and was also a talented artist and musician. She sat first chair soprano in choir, first chair clarinet in band, played bass guitar, and often performed as a classical piano soloist. She also won awards for her drawing and painting. She was also an accomplished athlete, earning 11 varsity letters in volleyball, softball, basketball, and track, in addition to being a cheerleader. Not surprisingly, she held many leadership positions in high school, acting as volleyball, basketball, and cheerleading captains, yearbook editor, and class president, to name but a few. In 1983, Shelly headed to the University of Illinois at Urbana-Champaign, where she excelled academically. As a sophomore, she was elected president of her residence hall, and in 1987 completed 2 bachelor's degrees, one in an honors biology, which sparked her interest in laboratory science, and the other a Bachelor of Arts in rhetoric, which focused on creative writing. Shelly then enrolled in the University of Illinois College of Medicine, graduating in an accelerated clinical program in Peoria in 1991. Her experience in the Department of Neurosurgery, working with Dr. Patrick Elwood, solidified her conviction to pursue neurosurgery as a career. Given her interest in basic science, Shelly volunteered in the lab of Dr. Charles Rigel, where she studied cocaine-induced seizures in genetically epilepsy-prone rats. Dr. Timmons matched into neurosurgical residency at the University of Tennessee, Memphis, and the Sims Murphy Clinic. During her intern year, Shelly met Russ Carter, a fourth-year general surgery resident. They began dating in the fall of 1992, Shelly's PGY2 year, and were married in Peoria that fall. Russ and Shelly welcomed their first son, Alex, in 1996, followed by Michael in 1997. By then, Russ was a young attending in general and vascular surgery at the University of Tennessee, and in the coming years would train as a cardiothoracic surgeon. Dr. Carter quickly developed one of the busiest chest practices in Memphis and was renowned for performing all aspects of cardiac, thoracic, vascular, and general surgery. While there, Russ co-directed the LVAD program, was an active transplant surgeon, and served as the chief surgical officer for Baptist Hospital, as well as CEO of his private practice group. Russ remains the director of cardiovascular surgery at Geisinger Medical Center, where he has built several innovative programs, all while maintaining a high-volume surgical practice. Russ and Shelly raised their boys in Memphis with help from Shelly's mom and dad, and in Danville with help from the school bus. With the parents running shuttles for them, Shelly and Russ made being at their kids' extracurricular events a priority, recognizing that their own hobbies would have to wait until the children were grown. Their son, Alex, attended the University of Colorado and is now stationed at Fort Benning, Georgia, where he's training to become an Army Ranger. Michael is also a student at the University of Colorado studying computer science, astrophysics, and math. His hobbies include composing music, skiing, and hiking. During her PGY 6 year, Shelly developed a plan to pursue a PhD in neuroscience. So in 1996, while while maintaining the position of Administrative Chief Resident, she began taking graduate courses and working in the lab of her thesis advisor, Robert Faring, studying the modulation of voltage-gated calcium channels and isolated CNS neurons using patch clamping techniques. During her training, Dr. Timmons had developed an affection for caring for trauma patients and saw potential in building a clinical research program at the Elvis Presley Memorial Trauma Center, better known locally as the MED, and one of the busiest Level 1 trauma centers in the nation. Working at the MED was to be a part-time job while she finished her PhD, and in 1997 she began her professional career as the Chief of Neurosurgery Service and Director of the Division of Neurotrauma at the MED while building a private practice at Sims Murphy Clinic. Incidentally, Russ entered his cardiovascular surgery fellowship that very same day. Shelly went on to serve as Chief of Staff at the Med and advanced to the position of Assistant Clinical Dean within the University of Tennessee. Her research enterprise also steadily built, with Dr. Timmons acting as PI for several industry-sponsored studies. In 1997, she garnered foundation and university support to initiate a trauma registry that ran continuously until 2010. This earned her an NIH grant as a site PI for the Traumatic Brain Injury Clinical Trials Network in 2002, the same year that she completed her PhD. Based on her extensive experience with decompressive craniectomies at the Med over a 15-year period, Shelly's published numerous peer-reviewed articles, book chapters, commentaries on neurotrauma and neurocritical care over the years, and recently edited a textbook entitled Controversies in the Management of Traumatic Brain Injury. Shelly's experience at UT perfectly positioned her for a move in 2010 to Geisinger Health System in Danville, Pennsylvania. She soon applied for and gained RRC approval for a new neurosurgery residency training program where she served as its program director until 2016. While at Geisinger, Shelly built a neuroscience specialty unit as well as developed specialty neurotrauma clinics for traumatic brain injury, blunt vascular injury, spinal injuries, as well as a peripheral nerve clinic. Given the adage, if you can't beat 'em, join 'em, Shelly was recruited to Penn State Hershey by Bob Harbaugh in 2016, where she now serves as Vice Chair for Administration and Director of Neurotrauma. She's enjoying the neurosurgical practice at Penn State, where she is one of 5 physicians providing neurocritical care in the neurosciences intensive care unit. She's developed a neurotrauma research team on campus and is planning a multi-institutional trial on prior anticoagulant use and prediction modeling in TBI patients. Shelly has long been a fixture in organized neurosurgery and has held numerous committee and leadership positions within the AANS, the Joint Section on Neurotrauma and Critical Care, the American College of Surgeons, the Society of Neurological Surgeons, and others. She's worked for years advancing the field of neurocritical care, and working with Bob Harbaugh, Alex Vlodka, and others was instrumental in maintaining neurosurgery's authority, legitimacy, and competency, leading to the development of an ABMS-endorsed subspecialty in neurocritical care. Prior to being elected into her current position, Shelly served as the chairperson of our Washington Committee, one of the most pivotal positions in organized neurosurgery, where working with Katie Orico and her team, she provided national leadership in the field of healthcare policy, advocacy, and medical socioeconomics. Ladies and gentlemen, I submit to you that today marks a new day for our specialty. In the 100-year history of neurological surgery, never have we had an AANS president who was an accomplished neurosurgeon, an NIH-funded neuroscientist, a renowned educator, an associate dean, national policy advisor, clinical innovator, daughter, wife, and mother. Please stand with me and welcome our 2019 AANS President, Dr. Shelly Diane Timmons.
Thank you all so much, and Rick, for that lovely introduction. Colleagues, friends, and family, it is my greatest honor to address you today and to have spent the last year in service to the American Association of Neurological Surgeons as president. I would like to thank the AANS membership, the executive committee, the board of directors, our committee members, and our professional staff for their outstanding contributions. The faculty and staff at Penn State University, especially Dr. Harbaugh, who have enabled me to carry out my duties this year, are owed a huge debt of gratitude. Finally, I'd like to thank my husband, Russ, my parents, my children, Alex and Michael, and my entire family for their enduring love and support throughout my life. I selected the science of practice as this year's annual meeting theme to draw attention to evolutions in medical and surgical practice and to how technologies of today can be used to advance knowledge through thoughtful analyses of clinical observations and experiences. By harnessing data and information from real-world human struggles with injury, illness, and disease, the science of practice can help practitioners and patients make the best possible decisions about care, especially in areas where robust scientific data are lacking. Furthermore, the meticulous observation of what we do every day in every hospital, office, and clinic, and on every roadside, sideline, or sickbed around the world can help our research hypotheses for other forms of scientific pursuit be stronger and better informed. Given today's technological and computing capabilities, our field is more poised than ever to learn important lessons from our extensive clinical experiences. This year is the 100th anniversary of neurosurgery officially being declared a specialty, as we've heard. Our professional environment over that time has become increasingly complex with the evolution of massive healthcare systems, increasing regulatory burdens, and a very convoluted economic landscape. Advanced imaging modalities, intraoperative adjuncts, and a knowledge explosion leading to increasing subspecialization have also contributed to this complexity. We as individual neurosurgeons find demands on our time and attention that seemingly have very little to do with our purpose for entering the field, to save lives and alleviate pain and suffering. One thing that is clear is that we must have tools for lifelong learning and assessment of our performance as surgeons in order to be the best that we can be. The American Association of Neurological Surgeons has long stood for critical self-examination. Based upon the practices of Dr. Harvey Cushing and Louise Eisenhart and their meticulous cataloging of patient vignettes, photographs, brain tissue, and pathological slides, the Society formulated a brain tumor registry very shortly after its inception. Our focus on the critical appraisal of results aims not only to improve individual surgeon performance, but to enhance our overall understanding of the utility of the operations that we perform and to advance the field. This philosophy has permeated the activities of the AANS over the lifetime of our society. However, in this complex environment, we must constantly ask, what are we best poised to address as a professional society? Throughout our most recent strategic planning process, in the subsequent streamlining and restructuring of our organization, and in all of our governance discussions, this is the central question posed. We can discern the answers to this question through observable phenomena, technological solutions, promotion of high-quality science and scientific publication, educational offerings, and exertion of our professional influence, all while maintaining our humanistic mission of bettering the lives of people worldwide with neurosurgical treatments. Current trends in population health management demand large-scale data collection, but the development, maintenance, and curation of databases and registries is expensive and labor-intensive. Hence, administrative databases founded on diagnostic codes and billing data have been relied upon, but they are often not clinically relevant. Clinical registries are not surprisingly being demonstrated as superior. Visionaries in my own field of neurotrauma saw the utility of large databases when the Traumatic Coma Data Bank was implemented in the 1970s. This database, supported by the National Institutes of Health, led to numerous important and seminal scientific manuscripts, including the impact of intracranial hypertension on outcomes after traumatic brain injury, the prognostic value of computed tomographic findings, the deleterious impact of hypotension and hypoxia on outcomes, and many, many more. While the TCDB was unique in its time, registries are now widespread. Further, large-scale multi-institutional collaboratives to glean massive data sets are becoming commonplace. For example, programs such as All of Us, also sponsored by the NIH and part of the U.S. Federal Precision Medicine Initiative, intend to gather a variety of genetic, biological, environmental, health, and lifestyle data from 1 million or more volunteer participants living in the United States to accelerate research and improve health. And this initiative is based right here in Southern California. Population statistics also help us understand the role neurosurgery should play on the global stage. The World Health Organization outlined unmet global surgical needs and galvanized the worldwide surgical community to advance education and promote policies to allow for greater access to surgical services for all. In our profession, as we've heard, the NeuroPoint Alliance, established in 2008 by the AANS, has served to inform the neurosurgical community of the utility of specific operations and the context in which they can best be performed. NPA was founded on the premise that rigorous analysis of neurosurgical practice will allow us to define our value to society and to our patients and produce meaningful quality improvement. To do this, we must have risk-adjusted data. So documentation of comorbidities and other predictive data points has been incorporated into most of the NPA registries to help patients and their doctors make more educated decisions about their own health care in real-world settings. Patients themselves are now being empowered to observe and interpret their own data in innovative ways. People are managing their own physiology with such home-based tools as electronic medical record or EMR portals, wearable sensors, healthcare applications on their mobile devices, and even remote monitoring of implanted technology, such as deep brain stimulators for movement disorders. While the use of big data and various artificial intelligence techniques have become an increasing focus in medicine, computing ability exists far in excess of how we've been able to utilize it for medical care and research. Commercial sectors have divined how to utilize predictive analytics to market online content and merchandise, but the field of medicine has in some respects lagged behind. There are numerous valid reasons for slower progress in medical informatics, including issues of data ownership and protection, and quite importantly, privacy concerns. However, EMR design has been another impediment. EMRs are now widely decried for impeding clinical care, but they also have impeded the development of large-scale data collection that can be used to conduct research, inform practice, and spur change more rapidly. For one, most EMRs function as they were designed to function, as administrative and billing platforms to which sequentially added on were clinical modules one by one. Secondly, the proprietary nature of these systems has limited what data sharing can occur, and interoperability between systems has hindered progress tremendously, with the notable exception of picture archiving and communication systems, or PACS. EMRs lack standard terminology requirements, uniform data fields, and have highly variable input methods, thereby negatively affecting data integrity. Data loss, data integrity, and data fidelity therefore remain major concerns. The hospital Internet of Things, such as IV pumps, bedside monitors, and wearable sensors, is not plugged into EMRs. EMRs have not incorporated direct physiological data archiving from the bedside and still rely on hand entry of values by nurses, resulting in only select data entry and potential for errors, when the capability exists to directly download many more of these data points with greater fidelity. If we had the data archived, we could then use AI machine learning and neural networks to predict physiological events such as deleterious intracranial pressure elevations, electroencephalographic instability, or the development of imminent sepsis, for example. Proprietary challenges have also plagued the physiological monitoring world, but solutions are available. Dick Moberg, for example, has made it his life's work to provide neuromonitoring tools for neurocritical care that provide simple, intuitive visual displays that make the rapid assessment of large amounts of clinical physiological data easily interpretable. Data and events are time-locked together so that events can be assessed not only in real time for their influence on physiology to guide treatment, but also post hoc for research purposes to assess event, physiology, and treatment effects on outcome, the ultimate goal. This technology was the first to gain access to all independent physiological monitoring tools on the market and put them together in one system, making rapid analysis of large amounts of complex and overlapping data easier for clinicians to interpret and treat. This year, this technology will be used for the first time in a large-scale, multi-center clinical trial of brain tissue oxygenation monitoring and therapy in traumatic brain injury. Other forms of medical information are not exempt from these problems. Until recently, anesthesia records had not matured much since Harvey Cushing developed the original handwritten anesthesia chart. Anesthesia information management systems, so-called AANS, used automated entry of intraoperative data now, but have not yet become universally adopted. Through scheduled destruction protocols, loss of radiographs was the norm before PACS were developed. Digitization of imaging would seem to be a solution to archiving for future study. Witness the vivification of a 19th century senator in this enhanced photograph using modern computing techniques on pre-existing imaging data. And no, it is not Bob Harbaugh. It is a real 19th century senator. Raw medical imaging data stored properly in perpetuity could be used for predictive and other analytics as computing power increases. But PACS are not without risk of data loss. Systematic loss, in fact, of radiographic images in PACS has been reported in the medical literature due to vendor incompatibilities, mismatched compression coding algorithms between devices, system overload and bandwidth issues resulting in image dropout, and collateral image loss from server or power disruptions or other less dramatic events. These types of data loss can occur undetected without robust systems of checks and balances, and must inform our own registry efforts as we move forward to incorporate more imaging modalities. Imaging-based AI has been used to identify early signs of breast cancer on mammograms, diabetic retinopathy, age-related macular degeneration, and retinopathy of prematurity. The field of neurosurgery, so reliant as it is on imaging, is fertile ground for AI implementation. For example, independent interpretation of images, integral to the study of traumatic brain injury and many other diseases, is time-consuming, costly, and plagued by inter-rater reliability issues. Technology exists that can automatically ascribe hemorrhage volumes, compartments, and thicknesses on CT images, measure midline shift and tissue deformation, assess status of cisterns and other cerebrospinal fluid spaces, reducing the need for human interpretation. Yet, this is not deployed routinely either for clinical or research use. Thoughtful deployment of AI with clinician expertise to create augmented intelligence is required. We should use AI techniques to analyze hard forms of data impacting neurosurgical care, such as imaging, histopathological findings, physiological data, or laboratory values. In fact, the ultimate registry may eventually consist of a true distributed network of properly designed electronic clinical records with well-defined, mandatory, discrete, common clinical data elements, minimization of those human interpretations most at risk for error, and robust interoperability to provide AI techniques with more accurate sources of truth upon which to build their algorithms. Data extraction and analysis methodologies, data ownership and protection, feedback to the system for clinical decision-making, and other higher-level functions will require significant ethical, regulatory, and economic consideration. However, one can envision a world in which data are cleaner, easier to share, and easier to use to answer key clinical questions, and in which practical AI tools help us make complex decisions. While randomized prospective clinical trials serve to answer important questions of treatment comparisons, they do not lend themselves well to surgical questions for a variety of reasons, as we've heard, not the least of which is that surgical skill varies across surgeons and for individual surgeons over time, and techniques and tools change over time. Comparing surgical to non-surgical treatments is further fraught with complications, including selection bias, crossover, intention to treat analyses, and lack of blinding. As a result, the use of prospective registries has become more and more ubiquitous in surgery because data collection can be ongoing over time and analyzed for multiple clinical questions at any point. The Centers for Medicare and Medicaid Services understand the importance of ongoing registry and data collection. The Coverage with Evidence Development Program allows payment for specific procedures for which research into efficacy and safety is ongoing, as long as patient data are captured in a registry effort for a comprehensive analysis. Our neurosurgical leaders are partnering to study mechanical thrombectomy and are in talks with the Food and Drug Administration through the Coordinated Registry Network for Devices Used for Acute Ischemic Stroke Interventions, or DAISY project, much more easy to say, These multi-institutional cooperative efforts will likely become the norm for the study of complex research into interventions requiring ultra-long-term follow-up, particularly those procedures involving implantable devices and biologics or the use of new devices. Learning curves do not end with the end of training, and competencies are continuously developing or degrading. The use of benchmarked practice data can enhance an individual surgeon's understanding of his or her own outcomes. Detailed practice data can also inform our societies on what knowledge or skill gaps exist in our members, thereby informing our educational offerings. The American Board of Neurological Surgery has committed to enhancing its review of practice data for certification through review of images and case details and conducting oral examinations based in part on candidates' own case data. Longitudinal outcomes assessment should not be limited to surgical results, but should incorporate other types of data, including patient-reported outcomes measures. The National Neurosurgery Quality Outcomes Database, or N2QOD, now known simply as the Quality Outcomes Database, or QOD, of the NPA, was the first American surgical registry to incorporate patient-reported outcomes measures. The number of manuscripts emanating from QOD overall, and the spine modules in particular, has been phenomenal. Our participating sites, neurosurgeons, and patients have contributed a wealth of information that should be acknowledged with gratitude. Recognizing the importance of these efforts, the Neurosurgery Research and Education Foundation has funded surgical efficacy studies via registry participation, in addition to the millions of dollars granted to more traditional forms of research. Ultimately, our registries will regularly incorporate results that can be parsed by institution, years in practice, or any number of putative influencers of outcome. Future NPA plans include improved interfaces for users, not only for participating sites, but for neurosurgeons to visualize their own data. Similarly, expansion of well-coordinated registry efforts can be utilized to inform groups on the appropriateness of the gamut of care, including diagnosis, testing, and therapeutics employed even prior to neurosurgical referral. This will help multidisciplinary groups, accountable care organizations, and patient safety organizations provide optimal care. To do so, we are striving to provide tools that are more affordable to neurosurgical practices, able to analyze data in real time, and incorporate multiple forms of these related treatment modalities. Through rigorous scientific examination of real-world practice data, we are influencing the system, and we are helping patients. We, as the American Association of Neurological Surgeons, must maintain relevance in the future by not only providing tools to gather high-quality data, perform appropriate analytics, and provide results to neurosurgeons, programs, hospitals, and healthcare systems, but also to inform governmental and payer policy. As long as we can provide unimpeachable, scientifically garnered, clinically relevant information, we will be poised to lead the non-neurosurgical community toward laws, regulations, and policies that will help our patients and not hinder access to the care we provide. A critical role of the AANS as a spokes-organization for our profession is in providing comprehensive identification and analysis of trends in neurosurgery and medicine, in public policy in North America, and educational needs around the world. Further, the AANS expends tremendous resources to help neurosurgeons respond to these trends, as do our joint groups with the Congress of Neurological Surgeons, such as the Washington Committee and specialty sections. One such recent issue that has come to the fore is the management of ischemic cerebral infarction. Recent randomized trials have demonstrated that performing timely mechanical thrombectomy is extremely beneficial to reverse and prevent progression of cerebral ischemia. As a result, volumes of this procedure have dramatically increased over the past 1 to 2 years across the country, highlighting a number of problems and opportunities to improve the overall organization of cerebrovascular and stroke care. Cooperation amongst neurovascular intensivists in the fields of neurosurgery, neurology, and radiology is at an all-time high, and we are working together to promote more rigorous certification and training accreditation programs. Because neurosurgeons frequently provide emergency treatment for stroke patients, advance the slide please, in partnership with other stakeholders, we need to consider a more active role in pre-hospital systems engagement, in organization of patient transportation, and in the development of evidence-based policies to inform designation of stroke centers. We should also be involved in describing the resources and experience levels required to optimally treat stroke, just as we have for decades in the field of neurotrauma. The role of a good leader is not to tell people what to think, but to inform them of the issues about which they should be thinking. The AANS aims to inform and to help. Our responsibilities to our patients and the public make it imperative that we insist on regulations that eliminate barriers to medical informatics and analytics. We must advocate for policies that put patient safety and well-being first. We must financially invest in the technological tools that we need to optimize our prognostic and technical capabilities. And we must continue to provide value to individual neurosurgeons around the world through our educational offerings, our scientific publications, and our projects and registries. We, as your leadership, are constantly aiming to provide the maximum benefit to you for your dedication to and participation in the AANS. Not only are we as neurosurgeons privileged to have had the opportunity of education, but we also have the awesome privilege of trust. Patients trust us with their lives, their bodies, their futures, an immense obligation which should drive us to constantly improve. Furthermore, where we do have economic or geopolitical advantages, it is our professional obligation to lift up those without. Promoting networking for those neurosurgery colleagues who wish to expand access to care in developing countries, providing donations for neurosurgical equipment and travel, conducting outreach for education and training, and giving access to scientific publications are all mechanisms by which the AANS has sought to do so. The science of practice should be used to provide meaningful predictions for our patients and their families when they are at their most vulnerable. Through the powers of observation, technology, science, education, and influence, and finally humanity, we gain the power of discernment, which will allow us both as individuals and a collaborative society to find our way through the dense forest of complex systems that surround us and focus on that which is of utmost importance, providing the best possible neurosurgical care to those who seek our help. Thank you very much.